Indirect acceptance, dietary health, and behavioral harm, systematic betrayal and emotional suppression. By Nisa Pasha, executive political health guru, peer counselor and educator, mentalhealthrevival.org. Mental health recovery is rarely linear. For many peer consumers, the path toward emotional regulation, physical well-being, and personal empowerment is deeply influenced by systems, environmental expectations, and behavioral norms. Lalatah's story sheds light on the often overlooked consequences of indirect acceptance, when social workers, case managers, and mental health systems silently permit harmful behaviors, suppress emotions, and normalize risk. This blog post explores Lalatah's lived experience navigating smoking, dietary habits, systemic betrayal, and emotional suppression, detailing the interplay between mental health, physical health, and systemic constraints. It also examines what can be done to support peer consumers like Lalatah, concluding with inspirational insights for healing and motivational outreach. Lalatah's environment, day treatment, home life, and behavioral expectations. Lalatah is a peer mental health consumer attending a day treatment program for adults with psychiatric conditions and co-occurring behavioral concerns. Her treatment plan involves therapy, structured daily activities, dietary guidance, and behavioral monitoring. While the program aims to support wellness, Lalatah notices an environment of passive tolerance and indirect acceptance that impacts her physical and mental health. Indirect acceptance in behavioral health. Staff and peers tolerate smoking cigarettes on premises and at home, despite known health risks. Behavioral warnings are inconsistent or non-existent, creating a culture where risk is normalized. Lalatah observes that the systemic silence sends implicit messages that smoking and the behaviors that accompany it are acceptable, even in the presence of medication use or physical health concerns. Indirect acceptance in dietary health. Lalatah follows dietary guidance emphasizing whole grains, oatmeal, and dairy, intended to support mood stabilization and emotional regulation. She experiences subtle but recurring gastrointestinal issues, incomplete elimination, accumulation of toxins, and recurring odors that signal internal contamination. Despite these reactions, staff and dietary programs reinforce compliance without adjustment, signaling that discomfort should be tolerated for the sake of healthy eating. Emotional and psychological impacts. The indirect acceptance Lalatah experiences contributes to a complex web of emotions and cognitive responses. Her internal landscape reflects both resilience and stress, shaped by suppression, betrayal, and systemic neglect. Feelings related to indirect acceptance. Suppression of anger and frustration. Lalatah refrains from expressing concern over smoking or dietary stress, fearing judgment or reprisal. Confusion and mistrust. She questions why staff tolerate behaviors that compromise health, creating cognitive dissonance. Internalized stress. Recurrent gastrointestinal discomfort, combined with behavioral risk factors, contributes to ongoing emotional strain. Sense of betrayal. The system's inaction feels like passive complicity, undermining trust in social workers and healthcare providers. Isolation. Lalatah feels alone in her awareness of harm, as peers accept smoking and tolerate discomfort without complaint. Psychological mechanisms. Cognitive dissonance. Awareness of health risks clashes with observed behaviors and indirect systemic approval. Emotional suppression. Anger, anxiety, and frustration are internalized to maintain relational harmony with staff and peers. Learned tolerance of harm. Repeated exposure to tolerated smoking and dietary stressors normalizes these conditions, reducing vigilance and self-advocacy. Identity conflict. Lalatah struggles between being a compliant participant and advocating for her own health and safety. Bullet summary. Emotional effects of indirect acceptance. Anger suppression and emotional containment. confusion about system priorities and personal autonomy, cognitive dissonance and internal conflict, distrust of social workers, case managers, and healthcare systems, emotional fatigue from repeated observation of risk behaviors. Dietary challenges, whole grains, oatmeal, dairy, and behavioral impacts. Dietary guidance in mental health programs often emphasizes foods that support mood, regulate behavior, and stabilize energy. Lalatah follows guidance including whole grains, oatmeal, and dairy, believing it will enhance emotional regulation. However, indirect acceptance and systemic rigidity contribute to physical depletion and recurring internal contamination. Mechanisms of dietary depletion. Incomplete elimination. Fiber-rich foods like oatmeal and whole grains increase stool bulk, but may not fully eliminate waste if digestion is impaired. Toxin accumulation. Recurrent retention of waste leads to systemic stress, musty odors, and physical discomfort. Behavioral suppression. Dietary programs promote healthy eating to stabilize mood, but suppress natural responses like anger, frustration, or dietary preference, which undermines emotional authenticity. Nutrient absorption disruption. Smoking and dietary stress interfere with absorption of key vitamins and minerals, depleting regenerative capacity. Physical and emotional consequences. Chronic fatigue due to incomplete nutrient absorption. Recurrent gastrointestinal stress and discomfort. Emotional suppression, as anger or frustration about bodily reactions is discouraged. Sense of injustice. Dietary compliance is framed as mandatory, while systemic support is absent for negative outcomes. Bullet summary. Dietary indirect acceptance consequences. Physical depletion and slowed cellular regeneration. Recurring bowel contamination and digestive discomfort. Suppression of emotional cues like frustration and anger. Cognitive dissonance between perceived health benefits and bodily responses. Behavioral health. Smoking cigarettes in day treatment and home environments. For Lalatah, the behavioral environment amplifies the effects of indirect acceptance. Normalization of risky behavior. Smoking is tolerated or passively accepted by staff and peers, despite clear health risks. Peer groups sometimes model smoking as stress management, reinforcing tolerance of harm. Systemic oversight is inconsistent, leading Lalatah to question her own choices and health priorities. Interaction with mental health treatment. Medication efficacy. Nicotine can alter the metabolism of psychiatric medications, diminishing effectiveness. Emotional regulation. Smoking may temporarily suppress anger or anxiety, but contributes to long-term depletion. Behavioral reinforcement. Smoking, tolerated by staff, becomes a default coping mechanism for many peers, including Lalatah. Bullet summary. Behavioral indirect acceptance consequences. Compromised medication efficacy and health outcomes. Temporary suppression of negative emotions, leading to long-term emotional strain. Reinforcement of harmful coping patterns among peers. Reduced autonomy and self-advocacy. Emotional toll and psychological harm. Indirect acceptance across dietary and behavioral sectors generates layers of psychological harm for Lalatah. Internalized anger and frustration. She suppresses natural emotional responses to fit system expectations. Cognitive dissonance. Conflicting messages about what is healthy versus healthy. Tolerated harm. Create confusion and stress. Trust erosion. Observing system inaction undermines confidence in social workers, case managers, and treatment programs. Exhaustion. Constant vigilance over her own health, peers' behavior, and systemic tolerance leads to mental fatigue. Peer perspective. Awareness of systemic betrayal may motivate advocacy and self-empowerment. Emotional suppression without outlets can increase anxiety, depressive symptoms, and cognitive strain. Recognizing patterns of indirect acceptance is the first step toward reclaiming agency and health autonomy. What can be done for peer consumers like Lalatah? Intervention strategies for peers experiencing indirect acceptance should focus on empowerment, harm reduction, emotional validation, and systemic change. Peer-centered approaches, self-advocacy skills, teaching peers how to articulate needs regarding health, dietary concerns, and behavioral management. Emotional reflection, journaling or discussion groups to process anger, frustration, or betrayal. Peer support networks, encouraging shared experiences to validate emotions and reduce isolation. Harm reduction planning, education on alternatives to smoking and strategies to manage dietary discomfort. Systemic and organizational strategies. Staff training, educate social workers and case managers on indirect acceptance, harm reduction, and emotional validation. Policy adjustments, ensure dietary and behavioral guidance allows for individualized adaptation. Transparent communication, inform peers about risks and coping strategies in a non-punitive, supportive way. Lived experience integration, include peers in program planning and policy decisions to address systemic gaps. Bullet summary, actionable steps for peer support. Journaling for emotional and physical awareness. Small group discussions on harm reduction. Strategies, mindfulness and breathing techniques to replace smoking. Peer-led workshops on dietary and behavioral autonomy. Advocacy for systemic accountability and individualized guidance. Inspirational insights and healing motivation. Despite systemic shortcomings, Lalatah's story demonstrates the resilience of peer mental health consumers. Awareness transforms tolerance into empowerment. Recognizing indirect acceptance patterns allows peers to identify personal and systemic gaps. Peer connection fosters healing. Sharing experiences with peers reduces isolation and validates lived experience. Incremental behavioral change is powerful. Gradual adjustment of smoking, dietary habits, or emotional expression restores agency and resilience. Community advocacy amplifies impact. Peers can educate staff and other participants, fostering safer and more supportive environments. Practical peer examples. Leading reflective circles on dietary and behavioral health challenges. Facilitating workshops on harm reduction and indirect acceptance awareness. Implementing journaling or mood tracking practices to monitor emotional and physical reactions. Advocating for alternative coping strategies like mindfulness or structured movement. Conclusion, from indirect acceptance to empowerment. Lalatah's lived experience highlights the complex interplay of diet, behavior, and systemic tolerance in mental health contexts. Indirect acceptance, when applied to harmful behaviors like smoking or rigid dietary compliance, creates cycles of depletion and emotional suppression. However, her story also reflects hope and resilience. Awareness of these patterns enables agency and self-advocacy. Peer support and shared lived experience facilitate emotional validation and collective empowerment. Incremental behavioral and dietary adjustments promote physical regeneration and psychological well-being. Advocacy and motivational outreach help peers transform systemic neglect into constructive change, fostering equity, health, and empowerment. Mental health revival, seeking to inspire a unique perception of mental health awareness and harm reduction.